Good afternoon, everyone. Welcome to this afternoon's session, which I'm delighted as at the African Centre for Migration and Society at Wits to be co-hosting with colleagues and friends from MSF. I've popped up a slide that hopefully you can all see, just with a brief overview of the programme for the next hour and a half. Just a quick housekeeping request. Please could people keep their microphone muted and videos off. Obviously, the different speakers, I will ask them when we move into the discussion to please turn on their videos if possible. I understand for many of us, Wi-Fi connections and data are an issue, so please feel no pressure to do so. But if I could ask that people keep their microphones muted, just to enable us to clearly hear each other. But I'd really encourage people to please make use of the chat box function. We're going to be monitoring that and pulling out questions and comments to assist us in the discussion. I've been looking at the participant list, and it's lovely to see familiar names as well as new ones. So for those of you who don't know me, I'm Jo Veery. I'm Director of the African Centre for Migration and Society. I'm going to be helping facilitate today. And as you'll see, we've set it up in a way that you're going to have an opportunity to engage with the study. Our colleague Vinyoak from MSF is going to be taking us through that just now with a pre-recorded presentation. We'll then move into a short opportunity for clarifications from the study. So here I would please request that this is about clarification and that we save the discussion for the next section of the programme. But as I mentioned, please use the chat box and drop any thoughts, comments or questions in there. Without further ado, I'm going to move over to my colleague Thea de Gruchy, who is going to be kicking us off with sharing a recording that will give us an overview of the study and the key findings. As we move forward, I'm going to be introducing the speakers, but I would like to do this as we move forward rather than at the start. So Thea, can I hand over to you?
And Jo, can you just confirm that you can see the screen?
Yes, I can.
Okay, great.
Good afternoon. Thank you for joining the MSF ACMS webinar. My name is Vinayak Beitbridge. I'll be presenting the findings from MSF's study done in the Limpopo Musina area as part of the BRAMU survey. The survey report itself is available for download in reduced format as well as in the long format. I hope that this small summary of the findings will be useful to stimulate discussion this afternoon. The Limpopo Mobility Survey was designed to produce reliable evidence on mobility trajectories and its link with migrants' health outcomes. Through an adoption of the life history calendar methodology, the so-called migration history tool, it aimed to generate a thorough descriptive analysis of 5 key populations that had the Limpopo region as its origin, transit, and destination site. So the 5 main regions are the reception center, Magogo's house, villages, crossing points, and Musina. In total, 1,375 people were interviewed, and the sort of breakdown across the different sites is given in the table. We'll start off by talking about some of the findings seen at the reception center in Beitbridge. According to participants along their migratory journey and describing the reasons that they move, most of them were leaving their country of origin to search for a job or for better living conditions in what our colleagues describe as survival migration. We've encountered almost no one at the reception center who reported fleeing political persecution. We also documented numerous instances of being an orphan as being a main driver for leaving one's place of last residence. Migrant journeys are usually quite short, and 71.6% of interviewees didn't sleep in the city or place they were passing through. Contrary to expectations, most migrants did not experience episodes of physical violence or health problems along the route. In fact, less than 3% of our interviewees, and this was a recurrent observation across all the different sites. In the interviews conducted, the fear of xenophobia and discrimination was widespread across all the main cities, but it's particularly high, the fear that is in Johannesburg, where 35% of migrants noted it down as one of their main causes of distress. Half the interviewees had experienced some kind of discrimination in South Africa, and 37% had suffered at least one episode of physical assault in the country. Although on average, interviewees had spent more than 5 years in South Africa, and most said that it was fairly easy or very easy to receive health assistance, almost 40% had never accessed medical treatment in South Africa. Police stations are the kind of structure where 51% of respondents spent the longest period of time, against 44% who had been detained for the longest period of time in a prison, while 5% had spent most of their days in Lindela. The living conditions and access to health in police stations are reportedly poorer compared to the ones in Lindela. Also important to note is that in Lindela, there's a high prevalence of sexual violence. Around 46% of deportees who were interviewed accessed healthcare at the reception center provided by MSF. The main services accessed by deportees were general consultations, followed by HIV-related services, testing and refill for the most part. Only a few respondents sought mental health support or support for family planning. Around a quarter of the respondents were tested for HIV at the center, and a similar percentage, a quarter, reported lack of time as a reason for why they didn't get tested. And around 38% did not test because they didn't think of it, and 7% because they were not aware of the service. When we inquired participants what other services MSF should offer, only 14% asked for food. 35% of them stated that the services MSF offered were enough, and very few requested hygiene products such as soaps and sanitary pads. In the survey done at the reception center, we found that HIV awareness was considerably high compared to other research sites, with almost 100%, about 97% of the interviewees having heard about the disease before. Most quoted sexual intercourse as a main mode of transmission. In line with the general trend in Zimbabwe, women are disproportionately affected by HIV. Nonetheless, the prevalence we found among female respondents of 22.6% is even higher than the one reported for the general adult population in the country, around 12-13%. Although 95% of the HIV positive respondents said that they took antiretroviral medication regularly during detention, only half of them had taken it on the day of the interview or the day before, suggesting lack of access. 35% of participants who were detained before 2019 reported being sexually active, which would imply that they engaged in sexual relationships during detention. Signs of sexually transmitted infections is high among all sexually active people, with nearly 22% of deportees presenting discharge or genital ulcers. The adoption of mid to long-term family planning methods is very low for single women who do not wish to get pregnant, suggesting a significant unmet need for contraception. As part of looking at mental health in general, we looked at substance use and abuse among the survey participants. There was very low prevalence of men responding to a high risk of having harmful alcohol consumption habits or alcohol addiction. There was about 20% of men leaning on substance use, drinking alcohol, smoking cigarettes, doing drugs as a means to overcome stress. 20% or so of female deportees displayed moderate or severe symptoms of anxiety disorder versus 6% of male interviewees. What's important is that in this female population, anxiety, depression, and suicidal ideation was highest at the reception center than for any other group studied. We'll now look at the survey results for Musina. In trying to understand the migrant histories and their main reasons to move, we try to look at the different conditions that force them to leave their places of origin. And these would include lack of access to basic amenities, unsafety or poverty. Although Central Africans were less likely to name poverty as a cause of distress, we found that in the place of origin, Burundians were significantly poorer than Congolese, who by turn were significantly poorer than Zimbabweans. Among all nationalities, Burundians were the ones going through more countries, with almost a fifth of them having lived in 3 countries or more before ending up in Musina. Migration to South Africa among migrants and refugees in Musina is non-familiar, with nearly half of them having started the journey alone, while about a quarter were with someone who was not a family member. Throughout the route, about 10% of the people we spoke to have experienced an episode of violence, mostly at the Mozambique border. We were particularly struck by the finding that our interviewees in Musina had been there for 9 months on average. It's way longer than what would be common for any kind of transit point. Zimbabweans, and especially Zimbabwean women, are staying even longer, for sometimes 16 months on average, as opposed to 9 months for Burundians and 6 months for Congolese. Unemployment, of course, is cited as a major challenge in South Africa. Discrimination and xenophobia, food scarcity, challenges with the Department of Home Affairs, crime, and the conditions in the different shelters they stay in. Among our respondents, about a quarter had already been physically assaulted in the country, whereas about 11% of our sample had been assaulted in Musina. Half the people who had experienced a physical event of violence suffer a disability as a result, but 80% of them did not seek medical help afterwards. In terms of access to health, about 30% of our participants had experienced a health problem in Musina, but about 2/3 of them did not look for medical aid. Zimbabweans were more prone to search for clinical support than their Central African counterparts. Language barriers and a sense of discrimination could have a significant effect on this. Almost 70% of our respondents did not have access to 3 meals a day on most days, and the percentage increases to almost 77% when only men are considered, with Burundians being more affected than others. This slide just documents the data around sort of unspecific signs and symptoms recorded of poor health, and a lot of this was linked to living on the streets or in the shelters. This slide just describes a finding that was put forward earlier about the generally high reported prevalence of HIV among Zimbabwean women of around 22%. They also show that among those who reported to be HIV positive, almost half were not taking their medication or had taken it more than 30 days before the interview. This was also consistent with high STI symptomology found among our respondents, with almost 20% having symptoms. Regarding family planning, and in line with the generally higher literacy and access to health among Zimbabweans, Central Africans compared to Zimbabweans showed a lower use of contraception and had more misconceptions about it. The prevalence of sexual violence in Musina was high, with nearly a fifth of people interviewed in Musina describing having undergone at least one type of sexual abuse with men being more affected than women. Nearly a quarter of men who had been living in Musina for a year or longer had survived some form of sexual abuse in the city, and this this component rose to 30% among those who were living in the men's shelter. In fact, the situation at that point was so significant that our team, which had gone in to do a survey, became operational on the issue of sexual violence. When suffering sexual violence, most people do not look for medical help afterwards. Nearly 3/4 of them did not reach assistance, and no women who suffered sexual violence looked for clinic support. This slide describes the finding that social perception and alcohol consumption were often seen to be linked, especially among Zimbabwean men. And they found particularly that men in Musina had some of the lowest levels of social support because they often found that they had nobody to talk to when they felt alone, compared to 70% almost of women who had somebody to talk to. And this also kind of matched the observation that Zimbabwean men showed higher rates of harmful alcohol use than other nationalities. We'll now look very briefly at Magogo's house in the Zimbabwean side of the border, where Malawian migrants were among the key interviewees for the survey. In addition to surviving conditions of intense poverty in their country of origin, many of the Malawian migrants reported lack of food and drought or financial challenges driving them to leave the country, as well as potentially the environment and the propensity towards natural disasters. The length of their trajectory was usually short, lasting not more than 12 days, although most of them hardly slept through the journey. And even though the journey was quite short, nearly a fifth of them had suffered some form of violence, mainly bribes and robberies in Mozambique. And nearly 40% of the Malawian migrants were reported to have had malaria since January 2019. Once again, our Malawian respondents described physical assaults, discrimination, and this being as high as 50% physical assault in Durban among Malawian migrants. But particularly regarding access to healthcare, 45% of the interviewees who lived in South Africa had never accessed medical care, and many of them said that it was because they didn't need it. In terms of the sexual and reproductive health needs, there was high awareness of HIV. There was low usage or low reported usage of condoms during sexual encounters, and a high proportion of Malawians who were interviewed who presented some sign of sexually transmitted infection. As you may be able to see, the female population among Malawians is disproportionately affected by sexual and gender-based violence. And this also correlates with symptomology for high prevalence of STIs. At Magogo's, we also saw very low rates of depression and mental health challenges, although the food scarcity seemed to be a major concern. We'll now look at some of the findings among the cross-border population between Zimbabwe and South Africa. In the cross-border population, nearly 60% of all the households surveyed had at least one international circular migrant who went out of the Zimbabwe and into South Africa and back. Most of them were men, over 60%, and most of them were in their 30s, with a mean age of around 31. Nearly 2/5 of the international migrants were also responsible for a child remaining at the origin, and almost 2/3 of migrants were sending money or goods back to their household of origin. And the bulk of those funds, nearly 95% of them, were used for buying food. And almost half the households that we analyzed received some form of financial support from migrants residing abroad. Migrants with international migrant household members more frequently were in extended families or were single parent households. And nearly 30% of their family members who were migrants were living in Joburg, and another 30% were living in Musina. Those who were based in Joburg were more likely to have left children behind and sent remittances than those in Musina. So this slide summarizes the health-related challenges at each of the 5 sites that we looked at: Musina, the crossing points, Magogos, in the villages, and at the reception center. And most of these we've talked about in some depth already, but as we've mentioned, a big challenge is that the poor uptake of chronic medications in Musina, low family planning uptake, as well as poor rates of HIV knowledge and high prevalence of STIs, as well as the mental health challenges of substance use, high rates of harmful consumption, and significant suicidal ideation among certain populations, as we've discussed previously. At the crossing points, again, we see high rates of sexual violence. At Magogos, we see large prevalence of STIs, especially among women, misconception about HIV and low use of contraceptive methods, and high rates of sexual violence, especially women, but also men. And in the villages, we see high HIV prevalence and not that much use of contraception and high rates of alcohol consumption. Finally, in the reception center, in addition to all that we've observed, what we also see is this high prevalence of HIV among women and high rates of anxiety and depression. All of these come together to have significant impact for MSF's medical operations, but more importantly for today's discussion for policy going forward. So what do these findings mean for migration policy and access to health? Questions that affect not just MSF, but all of us gathered here today who tend to take an interest and who are actively involved in addressing some of these issues. For one thing, I think what's striking is the 9-month-long transit, which is among the lengthiest in the world, apparently, and how it is associated with health challenges. Additionally, what's not clear from this data, which concluded just as the COVID pandemic hit, is what the impact of the COVID pandemic over the last year has been on migration and what the implications are for the findings that we've presented. While MSF has conducted a subsequent exploratory assessment after the COVID pandemic in September and October last year, those findings or that intervention was largely inconclusive because the rates of migration were just so low. The current MSF experience, however, suggests that the low access to services in the border region, and especially in Musina, strongly motivate for a more humane permit renewal system. And it's important that civil society urgently push for this through this discussion and through subsequent meetings. Thank you very much for your attention, and I hope this has been a useful presentation.
Many thanks for that, Bin. Just before we move on, I wondered if just two sort of, I guess, points of clarification, but also just to help lead us into the discussion, it would be wonderful if you could share a little bit more about your position in MSF. and why it's so important for MSF to have this focus on regional migration. And secondly, whether you could help us sort of begin to think through, you mentioned some of this in your final slide, but really thinking about what for you and for MSF is that key advocacy point, the key actions we need to be thinking about at the moment in order to affect change locally. So if you're able just to touch on those 2 points, that'd be great. And just to everyone else, if there are any clarification questions, if you can pop them in the chat box. Otherwise, we'll move forward into the follow discussion after we've heard from Vin on this. Thank you.
Hi, thanks so much for having me, and I hope that the suggested format that we used was effective. So yeah, my role as regional migration referent is really a response to MSF's operational contribution to working on issues of forced migration and displacement. MSF, as you know, strives to maintain an independent voice, which therefore gives it strength and credibility in situations where a lot of the victims of trauma, be it through economic strife or conflict, tend to rely on migration as a way out of their situation. And so my role is really focused on the Southern African region to try and understand the health needs of migrants and to try and ensure that they are able to access healthcare. And so I work with my colleagues in the Beitbridge project as well as in Swane, where we have two migration-focused projects, and we try to integrate their operational approaches in order to address the overall journey that migrants take from departure to transit to their destination. And then on the second question which you asked, which was around the advocacy, and yeah, the last slide kind of touched on it. We know that the permits that had expired and which were given this kind of grace period until the end of March will now be up for renewal. And according to South African Department of Home Affairs laws, people will have to travel to the Office of First Application in order to renew them. In general, many of them will only be able to travel to the three refugee reception offices in Durban, Pretoria, and at Musina, which are likely to be the only ones open. What we've seen from our experience in Musina is that if there's a huge influx of people traveling probably by bus or hitchhiking or however they have to travel to get there, many of them women and children, the social services in Musina, and I think Faith, who is going to be one of the panelists this afternoon, will be very well placed to comment on this. Those systems just won't be able to cope with the huge influx of people. And we will see the same kinds of challenges that this survey has documented: challenges of access to health, huge mental health stresses, the prevalence of sexual violence and generalized violence. So what we are really hoping that we can push for is that people who are in South Africa are allowed to renew their permits in the cities they currently live in, and ideally they should be able to do so online. And that's one of the key kind of humanitarian findings that comes out of this. And you know, given South Africa's focus on trying to contain the COVID-19 pandemic, having a huge number of migrants traveling around the country to renew their papers in about a few days' time, in crowded conditions and with no shelter and no social services available to them, it's only likely to kind of create pools of infection which will affect us all. So this is not necessarily to single out any one community as being more prone to spreading virus over another. It's simply the conditions of congested transport and so on. So yeah, for that reason, we are pushing quite strongly for the Department of Home Affairs to reconsider its approach to permit renewal, and hopefully these survey findings give us some sort of evidential basis to make that call with confidence. There are some questions in the chat, but I think, Joe, you're answering them. And I think without further ado, let me hand over to my colleagues on the panel. Thanks again for this opportunity.
Many thanks. I think one point of clarification, if you could help, is about the criteria used to define the 5 locations of the interviews. And I wonder if you've got any, if you would like to share any further detail about how those were identified.
I wasn't specifically involved in the study or developing the methodology, but what I understand is that through our Beitbridge project, as well as a historical project in Musina, coupled, I think, with the insights that were developed by our previous regional migration coordinator, Lisbeth Schockart, that's how these particular sites were identified. But in the course of this presentation, I'll quickly take a look at the broader methodology and see if there's any further comments, and I'll type them in the chat. Thanks for that question.
Thanks very much. And just to add to that, it really, as Vin has said, is about the ways in which insight into the cross-border region by MSF's operations, but also other research, including that by ACMS, where it is known from a mapping process where there are different groups of international migrants tend to be located. So I think important to recognize it wasn't designed to be a representative study. Rather, it was designed to be able to be descriptive around the different issues that were faced around these 5 different locations. But we can obviously return to that. And Sharon and Melanie, I've noted your questions, and I'll bring those into more of the discussion. So I would like to now move to invite Faith Ngari from Future Families based in Musina to share with us some of her insights. Faith is very familiar with the context, and hi Faith, I will ask you to share a little bit about the work of Future Families before you start. But from that, given your familiarity with the context around the border, particularly on the Musina side, what do you see on the ground as the greatest health challenges that migrants face? And can you see opportunities for using this research to think about how we can address the challenges that are presented? So I'm going to hand over to you. Thank you.
All right, thank you very much, and thank you, Vin, for sharing the presentation. Future Families is a social partner for the UNHCR. We normally provide assistance, access to healthcare, access to food, accommodation for new arrivals, particularly refugees and asylum seekers. And being in Musina, we cannot close our eyes and ears to the plight of migrants, and especially from Zimbabwe, being the biggest population in Musina. Therefore, in collaboration with the interagency working group, other stakeholders with Musina, we normally respond to the needs also for migrants, and migrants mostly, in as much as we work with refugees and asylum seekers. Well, the findings of this research, you know, it gives me a different perspective of a town that I know so well, and to know that some of these challenges that we normally talk about, now someone can put them down on paper, and especially when it comes to access to healthcare. Primary healthcare, it's fine. Going to the clinic, it's okay. But when it comes to access, when the migrants want now to go to the hospital for secondary treatment or for higher level treatment, that's the challenges. Because we all know that they are required to pay. We are all required to pay. But no one does the means test, and therefore all the migrants are put in one category. And like, for instance, today I had an asylum seeker telling me that he's required to pay 2,000 something and in a hospital. But nobody, and the classification is a foreign passport holder. Therefore, it's just a matter of where do you come from. If you are outside of South Africa, you are classified as a foreign person with a passport. But the means test from the hospitals, it's not done, either by us, unless maybe somebody approaches organizations such as Future Families or Red Cross, who normally provide a letter. We normally do that assessment and provide a means test for the hospitals. That is one of the greatest challenges. And then in the research, it was mentioned that STIs and reproductive health, I talked to one migrant from Zimbabwe, and her response was the reason why most of them don't go to the clinics for treatment for STIs is because they're either shouted at, they are told they are the cause or they are responsible for having contracted the STIs, and therefore most of them fear because of the attitude of the primary healthcare workers. I think that the fear that you are going to seek treatment for an STI and you'll be blamed for it just shuts people out of accessing that healthcare. Then, of course, the language. As future families, we normally provide translation or interpreters to accompany people who want to access healthcare. But that is not available to everyone, and therefore, and I think MSF team that was here can confirm that most of them choose to remain in their shelters because they fear they might go to the hospital and they might not communicate, or there will be no communication between them and the healthcare workers. And obviously, even the healthcare worker just makes assumption and they end up being treated with paracetamol. And that is what we hear. I don't know, maybe it's the same case with other places, but when there's this assumption or the knowledge out there that most migrants, whenever they go, there's no proper diagnosis, and therefore they are given just paracetamol in the clinics. So those are some of the challenges that we normally find or come across. And again, mental health and alcohol abuse, and especially those who require psychiatry evaluation. We don't have such services in Musina, and when it comes to psychologists, then the language becomes a barrier, and then the interpretation is, there's a gap between the interpretation because psychologists require that only a psychologist can interpret for a psychologist, and therefore most people with mental health issues are left for themselves, unfortunately. There are no such services here in Musina, and I think that is also one gap. Therefore, some of these challenges, the attitude and the requirement to the language as a barrier. And again, since COVID, all migrants who don't have positive identification, they are required to provide something to identify themselves before they access healthcare. And majority of Musina, people in Musina, they are not documented, if I may say, and especially from Zimbabwe. And therefore it puts a huge amount of work for organizations such as Red Cross, who have to write a letter, do an assessment before a person, accesses healthcare. And that delays, the treatment, or before the person is put on treatment, there's that gap. And again, the people or the migrants who are HIV positive, and they're required to have a referral letter from their countries of origin before they get that letter from organizations such as ourselves, and before they are put back in on treatment, there's a big gap, and they end up either lapsing and worsening, or maybe contracting other opportunistic infections. Therefore, looking at the findings and talking, it's only like 50% of the migrants haven't used the health services. The question is why? Is it that they don't have the information that they have a right? And I think maybe awareness is important, informing the migrants of their rights to access to health, and where that or the limits of their rights. For instance, the assumption of some of the asylum seekers that the UNHCR has to meet their medical costs at the health care centers or in the hospitals, not remembering that they are required to pay depending on their socio-economic circumstances. And one thing is, raising awareness, informing the people that need to. It's very good that the research talks about the DRC, the DRC community not having majority of them not having been tested on HIV, because they come with this assumption like we don't have HIV where we're coming from, or we are not, sexually active as a nation. And therefore, even ourselves, when we create awareness on HIV, for them, it's something that is far removed. Another community, even when you talk about HIV, they don't want to listen. So these dynamics that play about and considering the cultural backgrounds or the upbringing of a nationality, as when they come to a country like South Africa, where the information is available, but here they don't want to take that information. So whenever we see migrants community, and before they approach healthcare, it's not that they don't come or they don't contract illnesses when they are on transit, but perhaps some don't even know that they're sick until the moment they get in there and they can't get out of their beds. And because we have seen some cases of, and especially in 2019, there was so many cases of malaria and typhoid. And the person didn't know until they arrived here. And before they've taken the medication, the person is already worse off. Yeah.
Wonderful. Thank you so much, Faith. And thank you for your insights into the context that some on the call are familiar with and others are less familiar with. And I think importantly, hearing about the ways in which you try and navigate these challenges and the issues, for example, around malaria are very important for helping us think through broader implications around what's needed to respond to the challenges faced. I'm going to hand over now to Dostin Lakika. Dostin was involved in the field research, is a friend, a long-standing colleague at the ACMS, having completed both his master's and PhD with us. So it's wonderful to be re-engaging with you, Dostin, and thank you for being here today. Thank you also for contributing some comments in the text box, and I think that's really helpful in assisting people in understanding the method. And one of the comments I just wanted to sort of add is, in terms of documentation status, individuals weren't specifically asked around the documents that they held in terms of the ways in which this has been reported. But it's very clear that being undocumented itself a very broad framework around individuals who currently don't hold the documents required to be in the country legally, that was strongly correlated with the challenges that were reported to be being faced, particularly in accessing services. So Dostin, sort of building on that, it would be helpful if you could take a few minutes to share with us your experiences in the field. And I think what's particularly important around this study is the fact that it was piloting and applying a tool to assist in understanding the linkages between migration and health. So the use of tablets, for example, in the field rather than paper-based surveys, the ways in which participants were engaged in that process. And I'd be interested in what your biggest challenges, you as a field worker, faced in the field. So I'll give you 5 minutes and then we'll move on to further the discussion. Thank you.
Thank you so much, Jo. I think the main innovation of the research was the use of the tablets. And for that reason, we had to train data collectors on how to use the tablets. So it took about a week of training, and this training was followed by recruiting those who were qualified to work as interviewers. And 8 people were recruited to be deployed to many places where we thought we could encounter migrants. And those places were men's shelter, women's shelter, lodges, and the lodges are the places that migrants occupy when they come for the renewal of their permits at the Musina Home Affairs. There were also mosques, and we ended up going also to Home Affairs because that's where many of them were going every morning to try by all means to renew their permits or to get their permits for those who newly arrived. So, and various languages were used for the interview. We used Ndebele, Shona, Venda, Kirundi, Swahili, English, French, and Lingala. And Lingala was not previously selected as one of the languages of the interview, but we noticed that many Congolese migrants who entered South Africa from Limpopo prefer to be interviewed in Lingala because they come from various places in the country where Lingala is widely spoken. So only very few were interviewed in Swahili. Now, what are the challenges that we encountered during this process? Data collectors had some challenges using the tablets. It was very difficult from the very beginning to use the tablet. Some data was not entered properly, and it gave us some challenges on how to send them to be interpreted. So we had to retrain them again on the use of the tablets. But the main advantage of using the tablet is like the research is paperless. So we don't walk around with a lot of questionnaires and many papers that they have to use all the time. So it was very practical using only the tablet to gather, to collect the data that we needed. But we also had some ethical problems because in the tablets, there were some specific questions which were considered too private. And the interviewee had to listen to the question before answering it. But the language, the voice that was recorded in the tablet was very, very unclear, and it became a challenge for the interviewees to understand what was the questions all about. So in that condition, those questions were no longer private because we had to listen for them and try to explain what the question meant. So privacy was no longer there because of that problem. And also some people found it weird that the voice that was recorded was not the voice of the interviewers. So that was the challenge about using the tablet. But the main challenge also was about the outbreak of the COVID-19 pandemic. So all of us were mainly exposed to the high risk of being infected. Fortunately, during that time, Musina did not record any case of COVID-19, but many migrants that we took to the clinic developed some COVID-19 related symptoms, so like high fever, high temperature, or cough, and sometimes the clinic became also reluctant to provide treatment to those people. Fortunately, we had to recruit 2 people in the area who were helping to interact with the clinic staff to be taking migrants who needed treatment to the clinic. So that's also one of the reasons, because people were asking about documentations. The main reason why people don't seek help is because they don't have documents and they are afraid of going to the clinic because they can be arrested and deported. For that reason, even when they are sick, they don't go to the hospital. And some lodges were managed by migrants who live in Musina. And those migrants welcome some other migrants who newly arrived in the country. And they were accused by the community of making the lodges hiding places for cross-border migrants with COVID-19 symptoms. So we used to take the people from those lodges to the clinic with the MSF car, which was now seen by the community as taking COVID-19 patients to the clinic. So these migrants were responsible of the lodges, and they became afraid of the community and advised us not to come with MSF car whenever we needed to interview people who were living in the lodges. And there was also a team member who was originally from Asia with a Chinese looking, who was almost victimized by youngsters of the area they thought that she was a Chinese, and China was branded as the country that was spreading COVID-19 around the world. So initially, interviewers were advised to do more than 8 interviews per day, not more than 8 interviews per day. But however, since the outbreak of the pandemic and the lockdown decisions that was looming, we had to encourage them to interview as many people as possible in order for us to be able to reach the number that we needed for the interview there in Musina. So overall, these are some situations that we encountered during the fieldwork in Musina. Thank you so much for your attention.
Wonderful. Thank you so much, Dustin. And it's really helpful for us to be hearing about the approach in the field. You know, this is not easy research, and I really do commend the fieldwork team who managed to navigate many of these complexities. And it's also important to be hearing about the ways in which individuals who participated in the project were offered support in various ways, should that be identified as a need. And obviously issues around the ethics of conducting this kind of research are as important as the ways in which we determine a research approach. So Dustin, thank you so much for raising those issues. So I'd like to now move on to Aurélie, who coordinates MSF's global forced migration group. And so I will ask Aurélie to share a little bit more about that. And in particular, the ways in which this research fits into MSF at an international level, potentially in terms of the findings, but I'm particularly interested in also how this approach and this methodology contributes to the work of MSF, and what the kind of key lessons are in terms of approach, method, and potentially also the findings themselves. And what would it mean? How can we capitalize on these lessons learned? So I'll hand over to you for 5 minutes. And then again, we'll open up for wider discussion and to unpack some of the issues that have been raised in more detail. So thank you, and over to you.
Thank you, Jo, and thank you for having me. It's definitely a very, I think, interesting discussion. So how this type of studies fit into our own analysis in MSF of transit and migratory journeys. It was actually the first time for the operational center in Brussels to do this type of survey. And it's definitely very needed, because we realized for a long time that we missed information about the experiences of our patients along the way, and we know that we can learn a lot from medical consultations about our patients, about the vulnerability they face before arriving to our clinic or where they are staying. But there is also a very important need to protect the medical space. So we don't want to have doctors asking too many questions that are not immediately relevant to the care of our patients. But at the same time, we know migration is a determinant of health, and we know that there is a lot of relevance in understanding the experience that they faced along the way, and in the different locations where they've been staying before coming to us, also for the provision of the services and to best assist them. So this type of survey is definitely a very good way to complement the information that we can have within the care that we provide directly. Obviously, there are also ethical concerns about asking questions that are not directly related to direct assistance, and that's always a bit of a discussion in MSF. How far can we do that? We are not a research organization. We are service providers. We are medical humanitarian actor. So obviously, we need to do these surveys with the idea that it will help us provide better care. respond better to the needs, understand the needs better, and adapt our responses, which is definitely the most important aspect of doing this type of work. And I think that this research in particular was very interesting because we did it at a time where we were a bit wondering where was our added value in the region. And you can see from the results from these findings that, that some of the assumptions that we had were not correct. So it gives a new picture of the experiences of people on these routes. And if you compare with previous experiences we had, for example, working in Musina a few years back, then of course the level of violence was very different. We would respond directly to the effects of sexual violence, very harsh treatment of people while they were crossing the Limpopo River, cases of ill treatment and assaults that were quite prominent. Which was the main one of the main reasons for MSF to be there on the other side of the border and to be able to respond to really urgent medical needs in relation to violence. This is less the case today, but you can see that some of these needs have shifted, and it's important for MSF then to adapt to this shift. And I think this type of research, we need to do them on regular basis because it gives a picture at a certain time. But we know migratory trajectories can change over time, that the movements change, the profile of people change, and there is a direct implications of state policies as well in how vulnerability can be experienced on the way. So that's definitely something we are very interested in as an SF. In terms of findings as well, I think the realization that you will find maybe most acute needs in detention facilities, in police stations, or in detention centers. That's something that for sure is quite important and that is a concern to us. So that's something that we need to consider as MSF. What is our role in working in this type of environment, even if we have experience. So that's definitely currently on the table to understand better what could be done, because based on the results of the survey, this is definitely where we could have an added value. Then I think it's very important as well to for us internally in MSF, but also in other, not only in the region but in other regions, to really promote this type of work, because there's a lot of misconceptions about transit. And for a long time, as a humanitarian medical actor, we struggled with our assistance to people in transit. So there's been a lot of questioning around what can be done while people are moving, and you can see from the survey that access to medical care is not the primary concern most of the time. But I think we learn, from this type of surveys and from our experience on other routes, especially in Europe, for example. That actually we should see mobility and migratory trajectories not as a challenge, but as part of the context. And that, as an actor, we have to adapt to this context. And so what can be done? And for us, we see a different role and different needs and a different way to respond based on the type of transit. So understanding, mobility is a key element in the provision of medical services. Whether transit is short or it's long, then it will completely change the way we plan our project, the way we approach patients, and the type of services and medical activities we can actually provide. So again, this type of survey is very important because it helps us then define what type of care we can provide. If it's short, then you will not, deliver the same type of services. I'm talking, for example, about mental health. If you will see the person only for a few hours, only once, and the person is going to be gone in the next day, then obviously you don't offer the same type of services that if someone is stuck for 9 months, 10 months in the same location. And so that's a key element that we need to integrate in the planning of our humanitarian and medical response. Then I think it's also important for us to highlight the complexity and the diversity that we find along these routes. So the complexity of the movements And it's very important as well to influence policy and to demystify some of the assumptions that are used to develop migration policies today. So this idea that populations movements are very linear, that people come from one place to another, and then that, you know, this framework of push and pull factor is the only thing that matters, and that policymakers can, you know, create deterrence policies based on this idea. I think academic research has been very important to actually demonstrate it's not the case, that these movements are much more complex, and that vulnerability is experienced on the way as well because of very bad policy decisions. And then the complexity and the diversity of the profile of people that we find along these routes. So we know that it's most of the time we will find mixed flows, that people have mixed reasons to flee. And then it's also helpful to have this type of research to also debunk some of the myths around the vulnerability that is faced based on the reason to flee. So we know that it's not because someone is a refugee that it will be more vulnerable than an undocumented migrant fleeing for economic reasons. We know that it's not always the main reason, but obviously reasons to flee are important to understand maybe pre-existing medical conditions, pre-existing vulnerabilities, experiences of trauma. So that's very important. And then just to maybe conclude on what we can do as MSF, our main objective is to make it safer for people. That's, you know, one of the main objectives is to reduce vulnerability, to make sure that we can restore dignity for people that are on the move, because we know that people will be on the move, and there's no, you know, as long as they have no choice, then they will have to adapt and flee, unfortunately. So the policy dimension is very important, and we can see with this type of survey how some very concrete policy responses can decrease vulnerability. And then where it is actually exacerbating vulnerability, then we need to make it clear and then advocate for policy change. That was my contribution to the discussion.
Super, thanks, Aurélie. While I've got you, and just before, I've got some questions from the chat and elsewhere for others who've also contributed. I mean, obviously you've spoken about what this means for MSF, how it connects to the bigger picture, but I was wondering if there were any specific implications for what you're seeing around COVID and migration more broadly. So I was wondering if you could give us a very brief update, perhaps, on the COVID context around migration, and if possible with a focus on Southern Africa, but whether there are particular findings in this report that could speak to addressing some of the challenges that we know exist. So if there's anything you could reflect on, that would be a wonderful contribution. Thanks.
I think that definitely, and that's something I think Vin mentioned as well, we need to really look at these findings now in light of the COVID pandemic, and especially the correlation between the COVID outbreak and then public health measures and migration control. And that's something that we've seen in many places, and that I think where, as MSF, we have a role to play. We have seen border control measures exacerbating vulnerability of people in a time where actually we need to challenge policies that are also creating risk for public health, especially situation at borders. We've seen that first there's been that's potentially been an adaptation of how people move because of the border restrictions that have been created because of COVID, and that we see that in the region, but also in other regions of the world. There's better chance that you will have people stuck for longer periods of time. So all these bottlenecks, they are obviously of interest to us because, I'm talking, for example, about Musina, because that's where potentially we need different types of responses to take COVID into consideration. and to take it also as an opportunity to highlight the fact that migration policies are a risk to public health when they are indeed aiming at containing people in very, bad locations with no access to medical care or very, very bad living conditions. We've seen, results to collective quarantine, these type of policies that are very problematic, both for dignity, but also for health reasons and also for transmission reasons. So no, definitely, I think we need to look at it as a, we need to refresh a bit our analysis in light of this new factor, but also see it as an opportunity to highlight structural issues that were pre-existing COVID, but that just are actually worse today.
Great, thank you so much, Orly. And I think that really nicely ties in fact, to a question that I think it was Aaron Tesfaye has presented. Apologies if I've pronounced your name incorrectly, but really helping us sort of think about implications in relation to the ways in which South Africa's Department of Home Affairs is closing and hasn't reopened the offices where individuals holding asylum permits that need to be renewed every 1, 3, 6 months at the same place at which they obtained the original document are facing increasing challenges. One, the offices remain closed. We assume something's happening at the end of March because this is when the amnesty extension on all permits was placed. We don't know what the plans are for how to reopen those spaces. We know that there will be large queues and crowds trying to access documents. And we know that this all links to DHA's approach to having a single point at the border in Musina, where individuals apply for asylum and where they need to renew their permits, as in a containment measure to keep people in Musina and not facilitate their movement elsewhere. And I was thinking, I mean, I'm sure that Orly and Dustin also have some thoughts about this, and please put them in the chat box. But Faith, I was wondering if we could go back to you for a minute or two, just to think about your thoughts. You've mentioned the challenges around safe crossing and access to screening, but in light of COVID and in light of these additional challenges, what do you think we need to be doing in Musina now? What do you think needs to happen at the moment to ensure that people crossing the border, for whatever reason, are able to access appropriate COVID services and ensure that everybody can remain safe? So I'd be interested to hear your reflections on that. Thank you.
Wow, thank you. I think for one, I would call for the assistance of the call for people, and especially because even when right now when the border is closed on the side of Zimbabwe, people are still crossing. They are using the river or along the railway line there for illegal routes of entering South Africa. I think the call for the government or the South African government not to reprimand people who are crossing, and maybe they have a reason for crossing, so that they can be screened at the port of entry. And if then that's not the case, then I think that those services can be extended to the shelters that host migrants. If then maybe to go back to one person mentioned about the lodges which house people coming to renew their documents. Right now, the lodges are suffering. No one is coming. And the few migrants who are coming in, they're just staying at the shelter. I think either maybe capacitating organizations such as Red Cross, Future Families, who can perhaps then extend those services, in the community in the light of COVID. Because giving a practical example, on Saturday the 6th, I assessed some 6 young Somalis at the age of 19 years. They had just crossed and they were stranded in Musina, and nobody had screened them, and they had come all the way from Kenya, Tanzania, Burundi, all those countries. even the thought of, you're getting, you can contract COVID. I don't know what plans are there. We haven't had anything with regard to RRO opening, even if the communication from Home Affairs is they will open on the 31st of March. But there's need for perhaps in the anticipation that the Home Affairs will open on the 1st of April to put those measures in place, screening points at every possible place, in the malls, in the shelters, and maybe at the RRO. Thank you.
Wonderful. Thank you so much, Faith. As ever, important to ensure, and particularly in this very detached virtual world, that we're hearing very clearly from experiences on the ground. And as a researcher in a research center working on these issues, I know I'm not alone in being aware of the tensions and the challenges that can often exist in the ways in which research can be defined. What should we be researching? What should we be looking at? What's helpful? And importantly, what's helpful for ensuring that the work that's generated can be used by various audiences. And I think one of the things Sharon from Lawyers for Human Rights has made a very important point here about the research findings can support a lot of the advocacy measures that need to be undertaken. Now, there's a fine line, and I think everyone agrees here, and it's a constant sort of ethical challenge many of us again find ourselves in, is being involved as an academic, as a researcher, in ensuring that the work that I'm involved in is relevant to the local context, is relevant to the policy sphere, but equally it needs to retain academic independence, right? And this is important for ensuring that our research work can be used by others in a trusted way. And it's a persistent challenge. And I just wanted to ask Dostin to give a final intervention before we move to Lorena for a wrap up, about what your thoughts are, Dostin, both in relation to this particular study, but also the extensive work that you've been involved with ACMS, with Lorena, with me, with many others, around how do we work with communities, how do we work with migrant community sectors and the civil society and the migrant rights sectors to ensure that our research does align with needs on the ground without us becoming an advocacy-based research center, because there is a line between that. So Dostin, is that something you would be able to give us one or two thoughts on? I'll give you a couple of minutes to respond, and then we'll move over to Lorena. Thanks, Dostin, over to you.
Thank you so much, Jo. I think the question we are raising is very, very important, what we can do to assist migrants, whether they are legal or illegal in the country. I've seen that Musina is an overcrowded place where you see many, many migrants overflowing every day. And the main problem is that there is only that Home Affairs that is supposed to help all of them. And unless they have some other connections, they remain in Musina. Musina becomes a place of settling for all these migrants. And the challenges, the main challenge that they are facing is access to documentation, which very, very difficult for them. And because they don't have that documents, their integration in the area is very problematic in the sense of accessing health, as we said, because we found some people, the question was raised that no migrant, when the data were being presented, that they don't seek health. They don't seek health not because they don't want to seek health or they don't have any problem, any health problem. They don't seek health because they are denigrated, they are not accepted. And the issue of the paper is key, because once they are caught without paper, whether at the clinic or at any other place, they are facing deportation. So I think all that we can do, especially during this time, is to make sure that those people are treated with care and that their problems are taken seriously because not facing these problems is also putting the community at risk, especially during this time of the pandemic. So those who have some places where they can go to Durban, Cape Town, you can see when time comes for them to renew their permits, they have to fly, they have to travel from long distances to come to only one place for them to be able to renew. And renewing the paper or getting the permit is very, very challenging. So I don't know, maybe more research, as you said, as academics, it's not also our duty to be at the same time doing advocacy, or all we need to do is to produce knowledge and put this knowledge at the disposal of those who are able to use it. But I don't know if what the knowledge that has been produced so far has been used efficiently to solve the key problems that migrants are facing in South Africa. Thank you.
Thank you so much, Dustin. I mean, really important points. And Sharon, thank you so much for the inputs here. And I think that it really is about building these partnerships. And we know that quality research, I would argue, requires these various partnerships and engagements. Something that I find works very well is ensuring that we set up advisory committees for our research. And those advisory committees should be including individuals who are on the ground, both in terms of different migrant groups, but also in terms of service providers and civil society, as well as other academics. And it's through those debates and discussions that we can strengthen our research. I think it's also important that to recognize not all of us have the same skill sets. And I think the skills that we have, we need to apply towards a common good. So I think that the academics need to do the academic work. I think our colleagues in civil society are doing their work. And I think that collectively, these inputs all come together to this common aim and supporting, improving conditions and so forth. So I want to thank everybody very much. And I think that we've already touched on various issues that I personally, and I hope MSF colleagues also agree, would be interested in developing a sort of follow-up where we can maybe unpack some of these issues about the role of research in partnership with civil society and towards, improving context on the ground and how we navigate those sometimes difficult spaces. So it gives me great pleasure to hand over to Lorena Nunes, who is a friend and colleague at Wits University. Lorena also previously was based at the African Center for Migration and Society, although she now appears to be in space, I think. I'm not sure. So I'm going to hand over to Lorena, who's going to help us with a wrap up before we draw to a close. But please continue to pop any questions or comments, and even if we can't get to them now, we're recording these and we'll be using these as we move forward. So thanks, Lorena, over to you.
Thank you so much, and thank you for this invitation. Really, I was going to be part of it because I thought it was very important to know what came out of this survey. And then Joe invited me to give some closing remarks, which makes me then excited to see as well that I can relate again to Musina, a place I went precisely with Joe some time ago to do research and confirm the nature of that place in terms of how the whole continent somehow, whatever happens in the rest of Africa has an impact in Musina. Conflicts and disasters, various problems that push people to migrate somehow reverberate in Musina. You see groups coming. But also at the same time, Musina seems to reflect the inability of not only South Africa, mostly South Africa, but the region in general, to deal with migration in a more coordinated way. So it's not surprising that people get really stuck there for such a long time. And it's absolutely this waiting time, and it's actually at the same time a bomb that might explode at any time, precisely in situations such as like now COVID and other threats that might affect even more the population in transit, but also the local population. So all these dynamics are reflected there and show very clearly in the results of this survey. What I also appreciate about this is the effort to distinguish between different groups of migrants and the different vulnerabilities they are exposed to, and sort of undo the lumping of big categories of migration, as if migration was one type of movement and if migrants were one type of people. So by differentiating in 5 localities, and it also shows different profiles and probably different movements, different motivations, different pull factors, push factors that are important to recognize. And this is nothing new to the other people who spoke, Faith and Aurélie, and in terms of how they recognize in their own interventions with communities the diversity of migrants, and the need to then tune in to these diversities to recognize how these interventions can be more efficient, and at the same time to be able to use these diagnoses, these pictures, these the results of this survey and the everyday experience with migrants to inform policies. And in the chat group, and Joe also raised the point, the need to, for example, show more globally how the Department of Home Affairs is implementing policies that are actually damaging health and damaging the health of large population. And if they care so much for the local population, they're also damaging the local population's health. But it's not the blame to be put on migrants, but on the inability to recognize that public health imperatives should be prioritized. And if COVID hasn't shown that at this moment, I don't know what they're waiting for to really recognize when they're actually causing more damage than protecting life or protecting resources. What I also, is actually something that one could anticipate, but it's actually good to have it in the results of the survey, the impact on health of these living conditions on migrants, the prevalence of sexual violence, STD, abuse, mental health, and so on, in different degrees for men, women, in all these different points of contact. And so that means that somehow these are conditions people can live with, but actually impact on the quality of life for them and their communities greatly. And so you can imagine, I can imagine them not even consulting, because somehow they can cope with this burden, which will not disable them from carrying on or waiting or moving or hoping, but they are very debilitating in the long term. And so this there's something though I miss from this survey that I would like to maybe invite people to put together, because I think we all know there are resources here. No, there are 2 things I think I was missing. The one is somehow the violence seems to be omnipresent. Everyone suffers in some degree, but sources of violence are not identified. It's some like violence, they are exposed, and we don't know who are the perpetrators, or what are the circumstances where violence is exerted. That on the one hand, and on the other hand, what are the resources they might still have in this dire circumstances? What are the capabilities that might then help in interventions? Are there social networks, religious networks? What are the connections with home? As Joe and I, we did some time ago, trying to also locate the networks of care and how these relate to places of origin or places of destination, or the very place where they stuck for so long. So these two sides I would like to see if one can have more information on, because that also reinforces the interventions that so far very rich and very good. And yeah, I think that's more or less what I wanted to say. Thank you.
Wonderful. Thank you so much, Lorena, as always, for helping us see how all of these different pieces come together. And I really appreciate your 2 points about our need to better understand this omnipresent violence and better thinking about the resources that individuals have in order to support interventions. And I think that really this report, we hope, is a way to really be driving that question about what's next. I know we're a minute over time, and I want to thank everyone very much for finding the time to join us. I've added the report, which has just gone online on MSF's website, and we will send a follow-up email to participants where we can share that report directly. I want to thank you all on behalf of Vin, of MSF, and myself for joining us, on behalf of all of the team, and in particular to thank obviously all the participants in this particular research, their communities and constituencies who we are looking forward to continuing to engage with moving forward. And hopefully we'll be in touch with some follow-on engagements with you all. So thank you very much, and take care, stay safe.
All right, Joe, thank you so much.
Thanks. Oh, and I meant to say we'll also make the recording available. So if people would like that or to share with others, that will also be available. Thank you.